I'd like to welcome you to Smilow Shares with Primary Care. And we're going to be talking about gynecologic issues tonight. And let's advance to the next slide. Great. So this is a program that Smilow has developed with NEMG, and Dr. Karen Brown is my partner in crime here. It's a monthly lecture series that really focuses on primary care perspectives on cancer and hematology. For primary care clinicians, there are lots of other formats and venues to learn about cancer, but the aim here was really to develop a panel that would address questions that primary care has around cancer on different topics, and also to focus on teams working together in a specific region. So we're focusing on gynecologic oncology care today, and really in the westerly Waterford region. It's a monthly lecture series, first Tuesdays of the month from 5 to 6. And we have programs all the way through until June, and I'll show you at the end. I'm going to hand it over to Karen. Any other words, and to get started with our first introductions.
I would just echo your excitement at this series. Welcome to everybody who's watching, and gratitude to everybody who has put together this program. You know, in primary care, we do a lot of work, and we also rely on specialists around us when our patients get very sick. We take pride in recognizing when they get very sick and being able to expedite their care in a way that meets their needs, both medically and also psychologically. And new cancer is a high time of need. And so this series represents not just education around new cancer, but it also recognizes that we are actively working to build bridges between primary care, both through education, through some of our care signature pathways, and regionally as well, because we know care is relationship-based, and we hope that this will be part of building those relationships. So I am pleased to introduce Jeff Joseph. Dr. Joseph is now a gynecologist in the westerly region. He graduated from Block Island High School. Fun fact, and it's really true. His graduating class had 8 people in it. So talk about practicing medicine in a community and being from the community. His undergrad degree was in chemical engineering, master's degree in Georgetown, and then New York Medical College. He did a residency at Bay State Medical Center, and then he worked at South County Hospital in Wakefield, Rhode Island for many years, until he's joined Northeast Medical Group in 2021. And now his practice is GYN only, although he can say he's probably delivered over 3,000 babies in his OBGYN years earlier. We are happy to have him present some cases to kind of kick off discussions, and I'll turn it over to you, Anne, for additional introductions.
Great, thanks. And welcome, Dr. Joseph. You're a specialist, but tonight you're also primary care in terms of the gynecologic piece. So I'd like to introduce Johanna Diodario, MHSPA. She's a 2008 graduate of Quinnipiac University, a physician's assistant program. She's got clinical experience in hospital medicine, primary care, and gynecologic oncology, and also experience in patient safety and PA education. She's very interested in genetics, health and wellness, disease prevention, and she joined us at Yale New Haven Health in 2018 as the coordinator of the Sexuality, Intimacy, and Menopause Clinic. She enjoys helping women with cancer maintain healthy relationships and manage treatment side effects, and she's a member of the Society of Gynecologic Oncology, the North American Menopause Society, and the Scientific Network on Female Sexual Health and Cancer. I'd like to then turn to Dr. Mitchell Clark. who is an assistant professor in OBGYN at the Division of Gynonc at Yale School of Medicine. He did his residency at Yale New Haven Health and completed his fellowship training at the internationally renowned Princess Margaret Cancer Center at the University of Toronto, where he gained clinical and surgical expertise in all aspects of gynecological cancer care. He also was very much engaged in a rigorous research program, further understanding the role of surgery in high-risk ovarian cancer, and also during his fellowship completed a Master of Public Health degree and continues to actively research cervical cancer prevention at a population level using administrative databases. He's received numerous national and international awards for his research, teaching, and surgical skills, including the Society of Gynecologic Oncology of Canada Research Award, Award of Excellence in Minimally Invasive Gynecology, and Yale School of Medicine Teaching Award. Thank you, Mitchell. And then finally, Dr. Christi Kim, MD, FACP. She's an assistant professor in clinical medicine and a general medical oncologist with special interest and passion in gynecologic and breast cancers and lymphoma. She works at, she's at our Smilow Cancer Hospital Care Center in Waterford, and has also participated in Gynecologic Oncology Group clinical trials as a primary investigator. And as a member of the Society of Gynecologic Oncology Clinical Practice Committee, she co-authored Neuroendocrine Tumors of the Gynecologic Tract Update. And she's also an active member of the International Gynecologic Cancer Society and European Society of Gynecologic Oncology. She was appointed as an adjunct assistant professor at Icahn School of Medicine at Mount Sinai. She's committed to improve the lives of those who are impacted by cancer. And she feels really passionate about providing the best evidence-based therapy options personalized to each patient. So great faculty tonight. I will ask you to remember that we do have time reserved at the end for questions, and that's been some of the most interactive and really interesting sessions. So keep your questions, you can put them in the chat later or along the way. We'll keep track of them. One more comment, Dr. Brown, before we start.
Yeah, before we begin, I just need to recognize the fact that the New Haven primary care community lost one of its own last month. And I want to dedicate this session to Laura Whitman and also say a few words about her. After spending time at Duke, UNC, UPenn, and Case Western Reserve School of Medicine, Laura completed her residency in internal medicine here at Yale in 1996. And it was specifically in what we called an ambulatory care track. She was also a chief resident in the primary care center, which used to be located on Howard Avenue. And it was there that she and I worked together most intensively. She was recruited as a faculty member based on her excellent clinical and also educational skills. She demonstrated patient-centeredness, and her kind manner was obvious to all of us who worked with her, whether we worked with her as a patient in an exam room, in a clinic, conference room, or lecture hall. She was a leader in the primary care medical education, which relocated to the Cornell Scott Hill Health Center several years ago. She also was an author of the Yale Office-Based Medicine Curriculum, which is a case-based study that's used in medical residency clinics all over the country. She was a fierce advocate for vulnerable populations, as well as a fierce advocate for primary care. Those of us who practice medicine, we learn very quickly that there's no us versus them, and that we have another expression. I know we use it in this practice. I suspect it's universal, that there's a clear lack of justice in most cancer diagnoses. Laura's illness and death is no exception. The primary care community and the Yale medicine community has lost someone whose impact will be felt for years to come in the lives of those who she trained, in our memories and in our hearts. So with that, we will kick off with the first slide. Dr. Joseph.
Thanks, Dr. Brown, and welcome everybody. Our first patient is a 56-year-old, gravida 2, para 2, 2 vaginal deliveries. She's postmenopausal, and she presented to the emergency department with a 2-day history of abdominal discomfort. Workup, including CAT scan of the abdomen and pelvis, was consistent with gastroenteritis. She was treated with IV fluids, and she was deemed stable for discharge. A 6-centimeter left ovarian cyst was seen incidentally on the CAT scan, and the emergency room arranged follow-up with gynecology. I think right there is where we see a little bit of the power of EPIC, because I was paged. I think the emergency room physician was a little concerned that the patient wouldn't have follow-up. She didn't have a GYN. So I was able to review the record and request that they drew tumor markers and asked that she have a pelvic ultrasound before she was discharged. She wasn't able to get the ultrasound before discharge, but did get back in the morning. So by the time I saw her, pelvic ultrasound was already completed. So by the time she sees gynecology, the abdominal discomfort had improved, but she did note some abdominal bloating, which she attributed to a new plant-based diet. Past medical history, not too significant, hyperlipidemia. She'd had an appendectomy. Her family history, a little more interesting. A maternal cousin with breast cancer at age 45, maternal uncle with pancreatic cancer at age 60. Her parents, siblings, and children are all healthy. She was not Ashkenazi Jewish ancestry. The pelvic exam was normal external genitalia, normal speculum exam. The abdomen was certainly not acute, but there was a palpable left adnexal cyst. The transvaginal ultrasound that was ordered did show that it was a complex ovarian cyst, and thankfully the right ovary and uterus are normal. Again, I think that's where the ultrasound is a little bit more accurate test for gynecology. Remember, with the CAT scan, you need IV or oral contrast, and with uterus, tubes, and ovaries, those can be sort of exaggerated on the CAT scan. So we kind of live and die with the ultrasound. I had asked for tumor markers to be drawn. That was the CA-125 and the HE4. The CA-125 came back elevated. That's returned in about 24 hours. The HE4, unfortunately, takes about a week, and that was pending at the time of the evaluation. CEA and CA-19-9 were normal. With the elevated CA-125, I referred the patient to GYN oncology.
Thank you, Dr. Joseph. So I had the pleasure of meeting with this lady and reviewed the workup that had been completed by Jeff thus far. And I completely agree. The ultrasound is really such a more sensitive and a specific tool for us. And given the complex features that we saw, so some solid components, some abnormal vascularity within that cyst, this patient was counseled that she should really undergo a laparoscopic evaluation, and at a minimum, removal of that tube and ovary with frozen section, and plans for surgical staging if that was to reveal a malignancy. Most of these cases can be done laparoscopically now, but for this patient, we put the camera aside, and what was immediately apparent was that there was already evidence of disease outside of the ovary. This can certainly be missed on CT scan, especially when we see very small peritoneal-based disease. And fortunately, it's not often that those things are overlooked by a CT scan, but we do know that most women with an ovarian cancer will present at a more advanced stage, just due to really our lack of good screening and early diagnosis right now. And so because of this patient's procedure was converted to an open approach. That's really still the standard of care when we find disease outside of the ovary, but it never hurts to put a camera inside and just see what's going on first. And so we proceeded with more of a cytoreduction, or what we used to call the debulking. And now the goal is really shifted towards removing all of the visible disease that we see at the time of surgery, and that confers really the best survival for these women. So we completed that surgery without any complications, and she was discharged home 3 or 4 days after her laparotomy. And we referred her on to meet with our medical oncologists. And they're really an incredible part of what we do for these women, because it's a real combination of surgery and chemotherapy. And so she met with our medical oncologist to discuss chemotherapy, as she was found to have a stage 3C ovarian high-grade serous, which is the most common type of ovarian cancer we see. And we'll talk a little bit about the importance of genetics and why every woman with serous ovarian cancer is referred to meet with our wonderful genetics team. And this patient was actually found to harbor a mutation in the BRCA2 gene. Next slide. This is a really great figure to show sort of how exciting things have become over just even the last 10 years in this disease. For the last, if we look back here, 20, 25 years, really it was toying with which chemotherapy combination is going to give us the best outcomes. And those outcomes were still very disappointing for this disease. What we're very excited by are the advances in maintenance therapy, and our understanding of the underlying biology of most of these cancers and how that can impact what our medical oncologists and us are recommending for patients to go on after they've completed their chemotherapy. So next slide. This is probably one of the more important papers and one of the figures that gets put onto every talk, and it really highlights that this is no longer just a one-fit-all cancer, that we really go ahead and look at the underlying genetics of all of our patients' tumors. And why that matters is that it has been found that about 50% of women with serous ovarian cancer, high-grade serous ovarian cancer, will have an underlying deficiency in homologous recombination. And that means that about half of women are eligible for these new types of oral medications that are taken after chemotherapy and have really revolutionized the outcomes and the survival for women with a disease that many years ago had a survival that was measured in a few years. And we continue to look forward to seeing the excellent outcomes of the data from these trials. So with that, I'm going to hand things over to Dr. Kim to talk a little bit more about some of the nuances in these oral meds.
Thank you, Dr. Clark. So this is a PARP inhibitor. PARP stands for the poly-ADP ribose polymerase inhibitors. It's an enzyme that involves in the DNA repair through another pathway called pathways. PARP affects a single strand DNA breaks, and PARP inhibition blocks the ability of the PARP inhibitor to participate in the DNA damage repair. So it's what's called synthetic lethality. So where the tumor cannot really repair its own and kind of comes to a cell death. So it's most effective in the BRCA mutations, as Dr. Clark had alluded. About 50% of the serous ovarian cancer harbors HR homologous recombinant BRCA mutations. And there are 4 main PARP inhibitors, including olaparib, niraparib, rucaparib, and talazoparib. The first 3 are FDA approved for the ovarian cancers. The last one is for the breast cancer. Next slide. So this was a big trial that kind of led to the 2018 olaparib approval as a maintenance. So currently in the US, the PARP inhibitors are indicated as a maintenance therapy. So this is a breakthrough, and this kind of demonstrated we are curing some of the high aggressive ovarian cancer patients. I draw your attention to the 5-year mark overall survival. There are 73% patients that are alive compared to the 63% of the patients at 5-year mark. At 7-year mark, there's still strong separation of the curve. 67% are still alive, and about 46% are alive. And just to mind you that about 50% of the placebo arm crossed over to the olaparib arm, and which can impact overall survival. So this is really impactful and it's changing. Next slide. So this is just to kind of give you like what's new in ovarian cancer. I think what we call antibody drug conjugate, or ADC. This was just recently FDA approved. It's against the folate receptor alpha, mirvetuximab. So just kind of have a diagram. It's a little bit busy picture, but there's a warhead. It's kind of like a smart bomb, as antibody that targets the cell surface receptor, and then you link to a lot of cytotoxic drug. It's what we call payload, and the ratio can be high. So the potencies are quite remarkable. If you were to give the patients the same dose, it can be quite lethal to the patients. But the way that you design the antibody drug conjugate, you can deliver the drug in a safe manner and targets the cancer cell directly. And then the second pictured on the diagram is called the tumor treating field. This is already the technique that was approved for the glioblastoma multiforme, highly aggressive glioma, and also the pleural mesothelioma. And there are ongoing studies, phase 3, as to electric field that pulses through the skin and interrupts the cancer cell, that's impacting the ability to divide. Next slide, that moves to Johanna's talk regarding genetic testing.
Yeah, so the question is for this first patient is, could there have been some kind of early detection or prevention of her cancer based on her history? And I think in the primary care setting, that's really important to think about. She did have a family history, not a first degree relative. She had a cousin with cancer and I believe an uncle with cancer. And we think about genetic testing. There's a couple things I wanted to point out about some of the recent guideline updates for cancer genetics. The first is really important in the primary care world, is that the Preventative Services Task Force does recommend that clinicians at least assess women with a family history of breast, ovarian, tubal, or peritoneal cancer, or who have an ancestry associated with a BRCA mutation. So this is specifically for BRCA1 and 2, thinking about family history of ovarian cancer, which she did not have. But in the primary care setting, it's important to take a good family history at your annual physicals and identify benefit from a genetics consultation. First degree relatives of a patient with ovarian cancer, first degree relatives of a patient with pancreatic cancer should certainly qualify for genetic testing. Or of course, if there are multiple family members with various cancers, or somebody, for example, who's had a bilateral breast cancer or multiple cancers in one family member. So in this patient, it may have been interesting to ask, had your uncle had any genetic testing, had your cousin had any genetic testing, because that may inform this patient's genetic testing. Unfortunately, for people who are referred for genetic counseling and testing without a cancer diagnosis but a family history, the wait time is a few months to have genetic consultation and genetic testing. But in this case, because our patient is now diagnosed with ovarian cancer, and it may inform her treatment options, including PARP inhibitor therapy, she is, of course, expedited and has an urgent genetics referral for her BRCA2 testing, which came back positive. I'm a firm believer in genetic counseling. There are people who feel informed enough to order genetic tests in the community. Gynecologists are well informed to do that based on their level of experience with genetics. Up at UConn, there are some really nice educational programs to kind of educate you on how to do genetic screening. But really the most important thing is that patients need to have pre-test counseling and post-test counseling. And the pre-test counseling really needs to be thorough enough to be able to take a good family history, know which tests to order, determine if there should be panel testing, which company to order from, and then making sure the patient understands the possible outcomes and possible consequences of their test results. So again, there is a high demand for our genetic counselor colleagues, but I do rely on them a lot to help me with patients when I'm thinking about genetic testing. My last few updates before we move on is that there is some very new guideline updates from the National Cancer Comprehensive Network that we no longer formally, or the NCCN no longer formally recommends ovarian cancer surveillance, even in our very high risk populations, the BRCA1 and BRCA2 carriers. For many, many years, we've done transvaginal ultrasounds routinely. We've done CA125 routinely. And This is the first year that the NCCN has removed that from the guidelines. I apologize. And last but not least, the most important thing I want to share with you as well is knowing the terminology for cancer genetics in regards to mutation no longer being as often used as a term that we use. BRCA mutation, we use variant. So there's a spectrum now: pathogenic variant, meaning cancer causing; likely pathogenic, benign or likely benign variants, meaning the gene is altered but not necessarily cancer causing. And then this gray area called a variant of uncertain significance that we do not necessarily clinically act upon. So if you have a patient who has a VUS or a variant of uncertain significance in a gene, it does not necessarily mean that he or she needs to have any prevention, surgery, or any surveillance for that specific type of cancer related to that gene. So I hope that helps. This is my last slide before we move on. Very important, brand new in the New York Times. It was a joint statement from the Society of GYN Oncology and the National Ovarian Cancer Research Alliance. Just came out earlier this week saying that, again, we don't have great surveillance for ovarian cancer. And if there is a genetic risk, or even in women without a genetic risk, and there's an opportunity to remove the fallopian tubes, that should certainly be considered with any other surgical procedure under certain circumstances to prevent these high-grade serous ovarian cancers that we believe may be originating in the fallopian tubes. So hot off the press.
Let's start our second case. Our second patient is a 65-year-old gravid zero. She's a postmenopausal female referred to gynecology by her primary care provider for vaginal spotting. She reports spotting on and off for the past 2 weeks. This patient came from primary care, but we also see this patient from urgent or walk-in care, often seen if you can't see your primary care, or from the emergency room. Past medical history is significant. She suffers from obesity, type 2 diabetes, and hypertension. She takes 2 medications for her hypertension, as well as metformin. Her BMI is 40, so now class 3 obesity. Her last period was at age 53, and she did not take any hormone therapy after menopause. Family history notable for diabetes in multiple family members and coronary artery disease in her father. On exam, she is in fact obese. GYN exam is limited by her body habitus. Speculum exam reveals dark menstrual appearing blood in the vaginal vault, and the uterus and adnexa are not able to be palpated. So kind of following the algorithm with postmenopausal bleeding, it's stop the bleeding, make a diagnosis, and then make treatment options. With this patient, I thought the bleeding was a little too brisk to attempt endometrial biopsy. The danger is put the patient through the biopsy, but only receive blood. And I'm sometimes a little uncomfortable biopsying a uterus I can't palpate or see that well. So I elected to start Provera 10 milligrams daily and order transvaginal ultrasound. The ultrasound revealed a 60 millimeter heterogeneous endometrium, which is abnormal. The uterine length is 10 centimeters, which is generous, and no myometrial abnormality. I then performed an endometrial biopsy in the office, and it was returned as endometrial intraepithelial neoplasia. That's somewhat the new technology for complex hyperplasia with atypia. That diagnosis, I thought, should see GYN oncology.
Thanks, Jeff. And yes, we did have the chance to see this lady. And what we spoke with her about is sort of left untreated, this condition can progress into a cancer in about 40 to 50% of women. That's some of the data from the older term of complex atypical hyperplasia. And so there are a lot of different options for treatment depending on the patient's age, their surgical risk factors, and what it is that they'd like to do. Just to sort of trail off from this patient for a second, let's say this woman was young, maybe she was in her early 30s, and she had not had an opportunity to have children, and that was part of her family planning long term. We do actually now have some exciting data to show that using things like the progestin releasing IUD that we know very well from contraception can actually cause this to regress in about 80 to even maybe 90% of women. The downside is there that that's not a definitive approach. And if the underlying risk factors, so the diabetes, the hypertension, the morbid obesity, haven't been corrected, that patient is likely to rebound into a refractory hyperplasia at some point if and when the IUD is removed. The other population that we consider using either the IUD or an oral progestin in a more long-term fashion are those women who we meet who have really high surgical risk factors, sort of inherent in this population with the diabetes, the hypertension, the obesity, some of the cardiac disease that really put patients at risk of going to the OR. Sometimes we will choose to do a non-surgical approach in those women. However, in this lady, we sat down, she was seen by her primary care provider who helped with risk stratification and optimization for her comorbidities before going to the OR. And we consented her and booked her for a robotic-assisted hysterectomy, removal of both tubes and ovaries, and frozen section. You might ask, Dr. Joseph has taken the time to do an endometrial biopsy, and we have a diagnosis of a precancerous process. But if you look at some of the historical data, the risk of there being a concurrent, already invasive endometrial cancer can be as high as about 40 to 45%. And so because of that risk and the potential of a sampling error with an office-based biopsy, we do recommend that women have a frozen section of the uterus at the time of the procedure. If that does reveal cancer, then we do proceed with the appropriate staging, which typically involves some assessment of the pelvic lymph nodes. And so we put that for this patient. The standard of care for these surgeries really is now moving on with an MIS approach or laparoscopic. You may have some patients who ask you, they've read in the New York Times that robotic surgery is associated with worse outcomes. That's in cervical cancer, and we are very interested to see where that goes. But for endometrial processes, really the standard of care has been MIS, and we continue to see good outcomes with that approach. So this lady was found to have an early stage, so 1A, grade 2 endometrioid endometrial adenocarcinoma. And this is probably one of the more common, final pathologies that we see. What we do for all of our endometrial cancer patients is we screen them for mismatch repair deficiency or microsatellite instability through both the combination of the immunohistochemistry and the PCR. And that is both to screen for Lynch syndrome, but also to look for inherent somatic changes in the tumor that may not be related to anything in the family or the DNA. And I have to say, this is one of the most common questions I hear from women is they get a cancer diagnosis, and the first thing they're saying is, what do I tell my daughters? What do I tell my sisters? How can I inform my family on their risk of cancer? This patient's results did show loss of staining in the MLH1. However, that reflexes a test to look for an epigenetic phenomenon called hypermethylation in the promoter region. And that is not, when that is positive, that's not indicative typically of a Lynch syndrome. And therefore, those patients don't often or don't necessarily meet outward criteria to go on to meet with genetics just based on that result. However, they would then qualify down the road for any treatments or medications like immunotherapy that have shown promise in this subgroup of women. Because of the final results of her pathology showing some high-risk factors, so the grade 2 disease, the lymphovascular space invasion, we did ask Ms. T to meet with our radiation oncology team to discuss vaginal brachytherapy. And that is really the most common type of radiation women are now receiving for these endometrial cancers. It's typically 3 sessions, very well tolerated, with very minimal long-term toxicity, and really has shown to decrease the risk of recurrence quite significantly. Next slide. So I just wanted to highlight some of the sort of newer, exciting technology that we have in the field of endometrial cancer. I'm sure many of you who have been seeing women with breast cancer or other cancers have been familiar with sentinel node technology in those disease sites. But really, over the last 5 to 10 years, we've seen a huge influx of data in and around the use of a sentinel node technology in almost all of our gynecologic cancers, which is very exciting. pelvic node assessment is very important in endometrial cancer for stratifying risk and assigning adjuvant, either chemotherapy, radiation therapy, or both. And for years, that included a pretty extensive pelvic node dissection over a fair bit of space in the pelvis there. And so this trial, or more of an observational study, tried to quantify how many of these women were going on to develop lymphedema of the lower legs. And just like the difficulties in treating that in the upper arms and the breast cancers, we have had a real challenge in managing that lymphedema long-term with women who develop it in the lower extremities. And it's not a negligible number, and it depends on which of the gynecologic cancers it is associated with. And so we've got really robust data now showing that across all the different subtypes of endometrial cancer, that in women whose disease appears to be confined to their uterus at diagnosis, that sentinel node technology is safe, effective, and almost eliminates the risk of lower extremity long-term symptomatic lymphedema for those women. Next slide. So I'm going to pass it back over to Dr. Kim to talk a little bit about where we're moving in endometrial cancer and the excitement coming down the road.
Thank you, Dr. Clark. So this is an endometrial cancer. It's the most common gynecologic cancer in the United States, and incidents are rising, as you are aware. So 5-year overall survival for the localized early stage disease is quite good, 95%. For advanced stage, that's not the case. About 5-year overall survival is about 18%, and ultimately women die from succumbing to their disease. So our trend is more and more toward successful outcome and trying to kind of figure out what are the targeted approach. So based on the TCGA data, the endometrial cancers are classified based on the molecular subtypes. So I draw your attention to the left column. So there are 4 subtypes. One, the 2 on the left is called poly or polymerase epsilon, or alter-mutated tumors. These are, the incidence are quite small, about 2.6%, but their outcomes are quite excellent compared to the microsatellite instability or hypermutated tumors. These are considered hot tumor, and the incidence about close to 40%. And these are the type of tumor that respond really well to the immunotherapy. The 2 on the right, the copy number low or endometrial subtype, and the one that's the worst prognosis is the one called Serous-like or TP53 mutated tumor. Their outcome is quite poor. So based on this molecular classifications, the treatment is going to be changing, and especially based on the PROTECT-4 studies. Our pathologists are going to classify endometrial cancer differently than what we used to. So next slide. These are just to kind of giving you perspective. Pembrolizumab was approved for as a second line, regardless of the tumor type, for the MSI microstability, MSI high or mismatch repair deficiency tumors. But with the junction with the what we call oral tyrosine kinase inhibitor, lenvatinib, and this was this changing that we're seeing patients with advanced cancer settings are living longer regardless of the biomarker. So next slide. What to expect for the immunotherapy adverse events it basically can affect any organ systems, and most common organ that can be affected is thyroid, and people become hypothyroid and ultimately needs a replacement therapy. But key is early recognition and interventions, and have your subspecialist, your pulmonologist, gastroenterologist, dermatologist, endocrinologist, have a referral and have early interventions, because these are quite impactful therapy, and we want the patients to be on really effective therapy for long. Next. So it's just kind of giving you like a idea that the anti-HER2 therapy is not just for the breast cancer. Nowadays, at the trastuzumab in combination with a chemo and HER2 expressed advanced uterine serous cancer can improve the overall outcome, overall survival. And this was based on the Dr. Alexander Santon's work. Next. So that kind of brings everybody to the kind of over the clinical pearls.
All right, so let's review the clinical pearls. A transvaginal ultrasound is often helpful prior to gynecology or GYN oncology consultation. The ultrasound evaluates the ovaries more accurately than a CT scan and can measure the endometrium. And I think that if there's ever a question and you have to refer the patient on to gynecology or GYN oncology, get the pelvic ultrasound ahead of time. It'll make that consultation that much more thorough. Any person with ovarian cancer or a first-degree relative with ovarian cancer would benefit from genetic testing. And I think we heard tonight how to do that, how to kind of get in line for genetic counseling before the genetic testing. Ovarian cancer can be a chronic disease. One of our slides showed that with the new treatment, the life expectancy is much longer than we had years ago. All postmenopausal bleeding must be evaluated, even spotting. And remember the algorithm: stop the bleeding, make a diagnosis, and then treatment options. Order an FSH level if there's any question that a patient is menopausal or not menopausal. Again, 52-year-old woman who's had a few periods in a year. Is that postmenopausal bleeding or perimenopausal? So an FSH ahead of time is very helpful. And many gynecologic cancer survivors are candidates for hormone replacement therapy if needed. That's an important point as well. If it's not an estrogen sensitive cancer, then hormone therapy can certainly be investigated.
So, Anne, I can guide some questions if you'd like.
Yeah, I just want to remind the folks who are on the line to complete the survey when you're done to get your credit. And you can always email us with questions, and these are the upcoming ones. There is one question in the chat from Beth Allard. Maybe we can start there.
Yeah, and Beth, if you noticed, is actually on the panel for next month's session, so she's getting a little warm up here. So I think, Jeff, this is probably for you. Is there a place for endometrial biopsy in a premenopausal woman versus postmenopausal? When would you do that?
So I think an endometrial biopsy, I do it more often than not when there's a question. So remember, menorrhagia has an endometrial biopsy, and perimenopausal bleeding would as well. Because remember, tonight's topic was GYN oncology, but most of the abnormal bleeding I see is not going to be oncology, right? Even postmenopausal bleeding, it's probably 80-20 benign. So fibroids, polyps, endometritis, there's a lot of other reasons, which is why I do the biopsy and it doesn't go right to Dr. Clark.
So I have a couple of questions that had come to me through colleagues before the session that I'll ask. And I would also encourage anybody who's attending to please send in questions. This is a pretty great opportunity to have a panel of people who can answer them at a intense level. So one question that I have is about this fallopian tube study. So in the past, we also recommended prophylactic oophorectomy for many women having hysterectomy. And at this point, at least in my practice, there are a lot of women having hysterectomies as part of pelvic reconstruction. So they're not in the cancer world at all. And as a primary care clinician, I may offer some advice. And it comes back with mixed reception. Is that outdated? Is it just the fallopian tube now? Tell me how did this all evolve?
That's a great question, Karen. And we're still actually sort of going back and forth. That pendulum continues to swing. A few years ago, there was a really nice paper that came out to suggest that there may actually be some underlying estrogen still produced by the ovaries, even if it's not high enough to trigger the menstrual cycle. And so the pendulum swang to keeping ovaries in place for women, and the age seemed to be about 65 is what that study showed. Now, since then, there's been a few sort of large scale papers saying, that benefit gained there weighed against the potential of an ovarian cancer left undetected. And so there is a bit of sort of equipoise within the scientific community. I sit down with my patients. We try to do a more individual risk assessment. Is there a high risk of osteoporosis, heart disease, dementia, where those ladies might benefit from, even if there's still a little estrogen being produced there to maybe prevent some of those conditions that we know are associated with low estrogen early in menopause. And the other thing is where women come from in their own life experience. If someone they saw go through an ovarian cancer, I have to say those ladies are typically asking us to remove the ovaries at the same time. But we do think the majority of at least the high grade serous does come from the tube.
And of course, family history probably plays into that quite a bit, right? Yeah. Okay. Very helpful.
Wait, I have a comment about that. So
yeah,
this is something that I learned a long time ago, but which maybe everybody knows, but it's because developmentally, right, that the tissue that the fallopian tube and peritoneal that lines the peritoneum is originating from the same tissue that develops into the ovary. You guys can say it better. That's why we even care, right?
In a sense that it is. When we look at all the sort of epidemiologic data over the last 50 years, essentially anything that reduced the number of lifetime ovulations, so pregnancy, continuous hormonal contraceptives, breastfeeding, all of those things seem to reduce your risk. And so people thought every time the egg comes out of the ovary, that rupture, that repair of the surface of the ovary, that's eventually going to lead to your first hit and your second hit in that sort of reconstruction of the ovary. But now we've learned that's actually probably the content of the ovum, so the sort of pro-inflammatory fluid that's in the egg that's coming out, that's bathing the fallopian tubes on their fimbriated end. And they live in very close proximity, and it's that repeated pro-inflammatory exposure. That's at least the tubal hypothesis that most of us are sort of going with right now. And that's probably why all those epidemiologic factors hold, but it's less has to do with what's happening on the surface of the ovary to the ovary and what that ovulation is doing to the fimbriated end of the fallopian tube. And the data on this is really quite impressive in countries and centers that have been doing this for quite a bit longer than we have seen a nice decline in their population rates of ovarian cancer.
So I want to just add that the patients with the BRCA mutations, that by the time they undergo prophylactic oophorectomy, they already find existing tumor that are already formed, like we call stick lesions. So kind of give you like how the cancers are rising.
That's a great point. And last thing, I'll talk about the tubes because I'm obsessed with the tubes, if you can't tell. We actually have now open at Yale. We believe so strongly in this at a scientific level that women with BRCA2 mutations can enroll in a clinical trial that will remove just the fallopian tube and delay the removal of the ovary until menopause. And they'll be followed for quality of life measures as well as, of course, development of an ovarian cancer. But because ovarian cancers occur a little later in the BRCA2 women, this trial has been designed to evaluate if removal of just the tube would be sufficient risk reduction for that population. And we are now enrolling patients at both the Waterford and our New Haven Care Center.
That is fascinating. And honestly, as a primary care physician, I didn't know that. And so I think it's really helpful to bring out here where people may be, counseling people as to whether to participate in a trial like that it's a strong theory. Jeff, it looked like you were about to say something.
So all female voluntary sterilization now has gone to salpingectomy. So, back in the day, clips, rings, tubal ligation, using single port laparoscopy, that's all kind of gone by the wayside. I bet it's been 10 years now that voluntary sterilization is now a laparoscopic bilateral salpingectomy. And we start at the fimbriated end because we think it's the most important, and kind of tease the fallopian tube off the ovary through the broad ligament and get very close to the uterus so that, you know, the whole fallopian tube is effectively removed. It's kind of changed the surgery just a little bit, but it's still 3-5 millimeter ports, still a rather simple surgery. Back at, you know, when I was doing C-sections, if we had a tubal C-section, the same thing. No longer were we just sort of interrupting the tube, but removing the whole fallopian tube. And that's been quite a while now.
And I think
any reduction in ovarian cancer with that, or is it hard to tell because of there are other factors at play?
yeah, I think that's where the studies are going right now, Dr. Brown.
Yeah. Okay.
Is the risk reduction in the high risk population. It'll take many, many years to know if this brings the risk down of an ovarian cancer subsequently. But, you know, we've seen patients who do have these stick precursor lesions who then unfortunately have to have full, usually hysterectomy and oophorectomy afterwards if an incidental stick lesion is determined. And then we follow them along to make sure that they're doing well afterwards. But a lot of young women, I think, who are interested in permanent sterilization, but also feel like this is maybe something that they can really do to reduce their risk if they have a family history, even if the genetics are negative, they really are inclined to do something that's in their control to reduce their risk. And this is one thing they can do.
Great. So I just, John, I'm glad you were talking because I'll come back to you. And then I still don't see any other questions from our audience. I would encourage people to ask. But I loved your wording. You blew over it a little. It was actually, you know, sometimes when you hear things twice in 1 week, they stick. And so a week ago in internal medicine, we had a grand rounds from a faculty member named Anna DeForest, who has written a book, and her point was words matter. And she specifically said what you said, which is we don't call things mutants and mutations. They're called variations, and that wording is important. In addition to hearing that from you and her this week, I also got back a lab report on a patient with, I don't know, hemochromatosis or something, and it said mutant detected. And, you know, I had never been so kind of sensitized to that as I was with that. So I think it's helpful to remember that words matter. And the other thing that's helpful is this concept of, I guess it's futility, but advice now against surveillance. So in those who are at high risk, doing these regular ultrasounds and markers has not proven to be effective. And so knowing that that's now also within the gynecologic community, in addition to our, you know, kind of preventive health focused internal medicine community is very helpful.
And I think the background, oh, go ahead, Dr. Clark.
No, sorry, go ahead. I was going to say something more of an aside.
Real quick, I'll just point out that all the more importance now on family history and identification of genetics is really the key as far as prevention of ovarian cancer. Yeah,
and testing the mutation. Okay. Good.
What I was going to say just about one of the reasons probably that the NCCN has now dropped this is just the really poor performance of CA-125. You know, we order it, but there are so many things that can cause it to be elevated, whether that's diverticulitis, Crohn's disease, you know, UC, any sort of inflammatory condition, recent COVID. I had a patient who was on surveillance for ovarian cancer who didn't tell me she had COVID recently. Checked her C125, it was mildly elevated, obviously very anxiety provoking for that woman. And so, you know, in ordering that, it's always good to just sort of, I try to really tell patients, you know, if it's a little elevated and you have one of these other conditions, please don't interpret that as a test for ovarian cancer. And CA-125 has really helped us in so many ways, but has really caused a lot of anxiety for healthy women in other ways. And so sort of being cognizant of sort of how to interpret those results in the context of each patient. To try to reduce some of that anxiety until they get a chance to meet with one of us at the cancer center.
Thank you. This was just wonderful. I am so appreciative, and I know my primary care colleagues who are listening and who will listen later will feel the same. Anne, do you want to wrap us up? You had a question. If
I
you
have one more
before we
question.
wrap it up.
From the New York Times, it seems like there's some new studies coming out around estrogen hormone replacement therapy, and I think that always comes up. You've had if you've had cancer or you are at high risk of cancer because of a family member, what's the bottom line about, is it safe to take estrogen replacement therapy? In 3 minutes.
I'll take this one in 30 seconds. It's an individualized decision. Depends on the tumor, depends on the patient, depends on all other risk factors. Smilow does have a sexuality and menopause for cancer survivors program. We love to see women and talk about risks and benefits. For the most part, vaginal, vulvar, cervical cancer, yes, it's safe. Endometrial and ovarian depends on the tumor type. Dr.
And
Clark, would
breast?
you agree with that?
Yeah.
Absolutely. And Johanna is underselling her role in Sims Clinic. This is an incredible resource at Yale, one of the first in the country to comprehensively evaluate and support women who have been previously told that they are, not eligible or candidates for something that can really improve quality of life, especially in our young women who go on to develop a gynecologic cancer. And so it's very individual. I have patients who were on hormone replacement therapy, who came off because of their cancer, and their quality of life was so poor. And we really don't actually have prospective randomized data to say that it will cause your cancer to recur. And so it is important that you actually sit down with someone like Johanna or someone who has experience with this and hear the actual data, so that your patients can make a truly informed decision, and not just based on what their friends have told them or to do or not to do. And because quality of life is just as important as survivorship.
I think that's a great place to end. Thanks to all of our faculty for the great discussion, the cases. Thanks to our participants for attending, and please again tell your colleagues to attend or listen. These are recorded, so they're available, and we look forward to seeing you in the future at our next Smilow Shares, which is Renee. Can you put that back up for folks? Okay, well, that's all right. We'll send it around. It's always this same Tuesday at the same time, same place. March 7th, GI cancers. Yes, thank you so much. And again, please make sure to complete the survey. We really appreciate that. And have a good night, everyone. Thank you again.
Good night. Thank you.
Thank you,
Thank you.
guys.
Thank you.